Now it's time to move on to the next session. This session is about mastering complications in coronary intervention. The chairpersons will be Professor Sufia Rahman, Professor Vijay Harikishan Bang, Professor D.S. Gambhir, Professor Rais Uddin Mondal, Dr. Shams Munwar. Moderators for this session are Dr. Asish Dey, Dr. Mohsin Ahmed. Panelists are Dr. Monsurul Haq. Panelists are Dr. Monsurul Haq, Dr. Kumar Kundu, Dr. Ear-E-Mahbub, Dr. Zehad Khan, Dr. Saleh Uddin.
Assalamu alaikum. Good afternoon. After a long theoretical discussion, now we're going to the practical experience, the mastering complications in coronary intervention. Here you see Professor Sufia in the dais, our chairperson, and Professor D.S. Gambhir, Dr. Kumar Kundu, and Professor Rais Mondal, and Professor Zehad Khan also there. Now I'm requesting Professor Mir Jamaluddin, Director of NICVD and Secretary General of BSCI. He will talk on left main troubleshooting, how I bailed out. Professor Mir Jamaluddin, sir. Professor Mir Jamaluddin, sir.
Respected chairpersons, my teacher, Professor Emeritus, Professor Sufia Rahman, and all other dignitaries. My paper is LM troubleshooting, how can I bail out? This is the patient details. I do not want to see as because time is limited. What is the shadow in the left main? And দেখা যাচ্ছে না কমরোল আসছে দূরের থেকে অবশ্য তো ভালো দেখা যাবে না দেখা যায় না এটা আসছে না তো এটা আসছে না কামরুল গলাটা কাটে বলো if we see from close then we see that there is a ghost shadow in the left main, and as because it is far away from the from our chairpersons, I do not know whether they are seeing.
রান করছি স্যার এখন স্যার এখন করছি স্যার
আগেরটা বলতে still picture. This is the still picture. And this is the initial scenario of the patient, left main involving the ostium of the left circumflex and minimal lesion in the ostium of the LAD. And we have done the right side is normal, distal LM 30 to 40% approximately, ostial left circumflex 90 to 99% with RCA normal caliber, and LAD may be some plaque extending to the LAD. And so here the syntax score, and syntax score is 23. And we have done the IVAS pullback from the left LAD to left main as well as left circumflex to LM, where in both the vessels IVAS is used, and let us see what IVAS shows us. It showed that ostium of the left anterior descending artery is not significantly narrowed, but there is significant narrow of the left main. This is on the left panel. On the left panel, this is the left main, and in the middle panel, LAD ostium. LAD ostium is 5.54, and next LCX ostium, and LCX ostium we have also pulled back done from the left circumflex, and left circumflex is significantly narrowed. And that is why we have decided to do the intervention from left main to LCX. And accordingly, we have pre-dilated the left circumflex as well as we have deployed on a stent from left main to left circumflex. And this is the result after left main to LCX stent deployment. Seems to be good, though there is some haziness in the left anterior descending ostium of the left anterior descending. We post-dilate the left circumflex as well as we have done the pot, and we have recrossed the LAD, and we have done a KBI with LAD. And this is on the right panel, this is the result after KBI. This also looks good. And we have done IVAS from left anterior descending to left main, which shows significant plaque shift causing narrowing of the left anterior descending ostium of the left anterior descending coronary artery. So we have decided to give another stent to the LAD in the fashion of tap. And accordingly we have done the tap. After tap we have done the KBI, and after KBI we have done the port. And before, just after doing the port, we have seen that there is a ghost shadow in the left main. Then what is the proximal part of the left main? Luckily, my two wire was in situ, meaning that one was in left circumflex and one is in the left anterior descending artery. And I recrossed through this shadow sequentially from a small balloon to larger. And I have post-dilated this ghost shadow. In the middle panel, you are seeing the stent, distorted stent, how ghost-like shadow in the middle panel. And we have done the post-dilatation on the right panel in this ghost. And finally, after doing report on the right panel, you see the stent is inflated, but there is Vijay shadow of the stent. But what shall I do? Shall I put another stent here? Where to where? In which vessel I shall go? And that is why I have seen the last scenario. This is the scenario. Angiographic view is good, even though the stent is distorted, but patient is hemodynamically all right. And as because patient is hemodynamically all right, there is TME3 flow, and there is no impairment of flow in the LAD and LCX. At the moment, patient is all right. So I sent him to coronary care unit, and patient is all right. And this is my first case. And another patient, a 56 years woman, who had the history of non-STMI, post-MI angina, LVEF 44%, and this was the coronary angiographic findings. Not moving. RCA was normal, and on the left side, slide was not moving, but there was a significant lesion in the left circumflex as well as mid LAD. This is the second case, and you see on the right panel significant lesion in the left circumflex, and LAD is a doubtful lesion. And the performer wanted to, right side is normal, and performer wanted to do the left circumflex, and he was trying to left circumflex, and you see in the first cine on the left side, both left circumflex and LAD is closed. Just distal to the wire, the left circumflex, and from mid LAD, both are closed. Emergency call back, then they called me. Patient developed chest pain, hemodynamically became unstable, patient is mother of a doctor. What are the possibilities? Dissection, thrombus, spasm, what to do next? Whatever it may be spasm or dissection, I shall have to open. And so I tried, I went there and withdrawing the wire from the left proximal part of the left circumflex, tried to cross the wire into the LAD first and making a loop, and you see this is the picture. In the second view, it has shown that there is dissection from the left main, which comes up to the distal part of the LAD and LCX. Both LCX is closed and LAD is closed due to this dissection. However, keeping that wire into the dissected part, I have crossed another wire into the LAD, and CPR was giving, and subsequently I have hurriedly I have given 2 stents sequentially from distal to proximal. And after giving this stent, though I am seeing that proximal LED, there is still dissection, but I have to treat the left circumflex as because I shall have to cross over. And that is why, keeping in this condition, I have crossed the LCX lesion and pre-dilated the LCX, and I have given one stent into the LCX. And after giving this stent, then I have given LM to LED, another stent, and post-dilated, and this is the this is LED and this is LCX. Both the vessels are patent, and my job is over. Treatment decision should depend on each patient and each lesion. In bifurcation lesion, provisional single stent strategy is still the default approach in majority of cases. Here is not bifurcation lesion, but it is the iatrogenic bifurcation lesion. And the left circumflex ostium is always a mystery, even you have done all the things right. Ostial branch lesion does not come alone and usually involve main branch. And complication of PCI management requires preparation, early recognition, and knowledge of effective techniques with good team effort. And this is my team, and we have finally saved the patient.
So, Professor D.S. Gambhir, I just one question from up to you. From the first case, you show there is a left main to LCX lesion, also LED, also some haziness. Is it possible go to the kissing balloon on the left LED? Now putting the double stent strategy in your case, in these cases, is possible? LED is the parent vessels, the main vessels. Is possible to kissing balloon left LED left alone? Is your comments in the case? Yeah.
Well, I think you first always try a kissing balloon inflation. If you feel after kissing balloon inflation there is still a lot of recoil and into the side branch, and if if you have the FFR facilities, you can do FFR. But I'm sure FFR would be all right in majority of these patients, because this has been shown elegantly by Korean workers. But if FFR is low, if it is less than 0.8, then it is good to put a second stent and not to leave it as such. So it all depends on from case to case, but I think the decision has to be based primarily on IVUS and secondly on FFR.
I had an idea to do only single stent, and that is why I have done crossover from LM to LCX, as because there is significant lesion in the ostium of the left circumflex, and by IVUS I have seen that there is no significant lesion in the ostium of the LED, and accordingly I have decided. And then whenever, after giving the first stent, when I saw that there is ill looking of the ostium of the left side.
So what was that? What was that according to you? Something at the origin of the left main, you saw some ghost shadow. According to you, what was that?
In left main?
Yes.
That is the distorted stent.
Yes. Exactly. This does happen when you put a guiding catheter and you're trying to fiddle around. The guiding catheter gets sucked in and it may distort. This is longitudinal distortion of the left main stent. And this can just be corrected by either balloon dilatation, but I think better would be to put another stent. Although you're putting more metal, but sometimes you may not be able to get a good angiographic and IVUS result by just redilating it with a balloon, because the stents get crumbled up. But if you are sure that the stent has nicely got tacked up with the wall and there is no chance of thrombus formation, you can leave it. But if you have got even slightest doubt in left main, don't leave it. I would prefer to put a second short stent over there and crush this against the wall of the left main.
Can I ask you one thing? Is that when you have a crumbled up or damaged or longitudinal damage, whatever we say, if that is in the main stem, first thing you will correct it, or you will you need immediately second stent strategy. First you will put a balloon and try to correct it, and then if not corrected, probably second stent. Is that right? Do I understand correct?
Yeah. You first try a big size balloon of the size of the left main. Inflate a short balloon over there, then do a IVUS. Because without IVUS, you can never know that some of the struts may not be well opposed to the wall of the left main. If you don't find that, then obviously you are done. But if you find that there are some struts which are still hanging in the left main, I, for one, would never ever leave anything in the left main which is doubtful to me. Then I don't mind putting in a short stent. Yes, I know I am exposing more metal to the left main, but then my first priority is immediate. I think that should always be a lesson. Your first priority is that patient should go out of the hospital walking and in a healthy state, because left main, if there is a thrombus formation, can take away the life within minutes. So you put a short stent and then let the patient go. He may come back to you with the restenosis, he may not come back. So be very sure that you are not leaving anything hanging in the left main.
As
What I'm
because
trying to, 1 second, I want to clear one thing that say you put a short stent, second one for the better completion of the job. And how often or what is the chance of having that it has not ironed the old one properly?
No, again, after putting in a short stent, you again do IVUS. We have done it at least in 5-6 patients in LAD in left main. You again do IVUS and you will see that the stent struts which were hanging earlier have been well opposed into the wall. But the new stent has pushed this struts which are
Because they have
hanging.
also the
they have got crushed
holes,
to the wall.
they have also holes. So
No,
it's not
IVUS would show you everything.
not a covered stent.
The ghost stent is well inflated, but still it is distorted. So I can give another stent, but that stent minimum stent is available in my hand is 412, but it is maybe 6 millimeter or 7 millimeter. How shall I give it? It will float 50% in the aorta and 50%
There is an issue in that.
there is also two stent, one stent in the LCX and another in the LAD. So in which direction shall I go?
Yeah, there is
no scope for giving another
Yeah,
stent.
this is the issue because of the shortness of the left main. Now, if your 1 or 2 millimeter of the stent is hanging out into the...
That is all right.
I don't mind that.
That is all
I
right,
don't
but
mind
if
that.
3-4 millimeter,
But
how
if
shall
there
I-
is a longer length outside, I don't mind putting this stent into the LAD, putting this further into the LAD and again going back into the circumflex and again doing a kissing balloon and then completing the procedure.
That
I don't mind that
I
because
could.
even if 2 millimeters go into the LAD and 2-3 millimeter and then again do a
One
kissing.
second recross and 1 second.
Yeah, because one thing which I would like to emphasize, and I am being very strong on this, is never leave anything in the left main.
Left main. And finally, this patient after 6 months came with restenosis, and we had to send him to CABC.
Yeah, so
Came
if
to
you
restenosis.
the same thing happened if you
I have one question, sir, regarding this type. If we keep the patient like this, with the stent distorted in the left main, is it wise to send the patient home with this type of stent in the left main, because that is the lifeline? Because restenosis is good, that did not kill the patient, but if the patient developed stent thrombosis, what will happen to him? Number one. And second question, transradial route, it is common. The same thing happens in one of my cases. And the second time when I try to engage the catheter through radial route, that is very difficult. Alignment is very difficult through radial route. So I go through the femoral approach. So that gives the catheter a good alignment, and subsequent repositioning of the second stent and post-dilatation become very much easier. So what is your experience regarding these two?
No, I think your first question we have already discussed, we have already answered, that do not leave anything in the left main distorted, undistorted, which is hanging into the wall, into the lumen of the left main. Don't leave that. Because your first priority is to prevent stent thrombosis. Because stent thrombosis is going to kill this patient, whereas restenosis is not likely to kill. And restenosis may come after 6 months, 8 months. So your first priority is that patient should go out of the hospital. So that's first thing. You may have to re-stent, put another stent in stent, do it. And number two questions, yes, you can do femoral approach because of better alignment and all those things. That is, of course, the individual own choice.
Thank you, sir. Excellent presentation, sir. So, why dissection is the occur in this LAD, sir?
Only one view I have found there entering the cath lab, that is guide is in situ and wire is in the proximal part of the left circumflex. No left circumflex, no LAD. Most likely this is due to the guide induced. Guide catheter was extra backup guide catheter.
Excellent, sir. Two cases for the young fellows is that you're so much expert operator. The dissection can be occur by the guide catheter.
Regarding guide catheter, we should have to tell that coaxial alignment should be there. Coaxial alignment should be there. And if this alignment is not coaxial, it may cause any type of problem like dissection, and which may give rise to catastrophe. Professor Deman.
I want to have a comment with some comments regarding this.
Second case.
I was when I was a fellow, I went to a Delhi for a Sky Fellowship training. Professor Ashok said there repeatedly told us that when you're doing a PCI, you should be careful about two things: distal end of the catheter and distal end of the wire. And this is one example of this,
right.
That distal end of the catheter causes the dissection and causes the
Distortion of
perforation.
Distortion of the stent also.
You
All
have,
the things.
you have to add another thing. It can happen with your diagnostic as well.
As well.
So
Yes,
you
ma'am.
have to check that
Yes,
as well.
ma'am.
You have to add
distal end of the
diagnostic
catheter
as well.
and distal end of the wire. These
Yes.
two are the most 99% of the complications in PCI and intervention occurs by these two.
Yes, Professor Diman, I was trained with him for 6 months. He always told, show me the tip of the wire, show me the tip of the wire, very frequently. We became annoyed. Why he is telling, show me the tip of the wire, show me the tip of the wire? And subsequently he told us that this is the thing, so you should always take care of this guide catheter as well as tip of the wire.
Thank you, sir. Thank you,
These are
sir.
important things to see, but
Thank you all.
I don't agree that 99% of the complications occur because of these two things. No.
No, that is not.
There are other things which
Many
there are
of the
other things
complications.
also.
Many of the complications. Thank you, sir. We move
I
forward.
think it's better to say that when we are doing, as I always say, that there's nothing simple, nothing quick, nothing will come out without complications. So whatever you use, I always say if you're doing a case, first see the patient, see what you're going to do, and then investigations you have done for your sake and for the patient's sake, that also you go through what is there to notice or not. And then the third one is your equipment. And then if you check those and they are okay, there is a less chance of having any sort of complication, but there can always be a complication at the end of the day. But you must prepare for the worst and be happy with what you have got.
Thank you, sir. Now, Dr. Sanju Karla, our international faculty, also our closest friend of Bangladesh. He'll take have never seen it before. Dr. Sanju Karla.
Okay, thank you very much, everybody. I have the pleasure now of presenting to you one of the messes that I've made that I like to call crash and burn, because it was just one mess after another. And hopefully you can see how a systematic approach to analysis of these things can help learn from the complication and make us better operators. My disclosures. So this was a 58-year-old with dyspnea, had previous coronary artery disease that was stented and had known hypertrophic cardiomyopathy. Septal ablation 3 months prior was very successful. He went with a provocable gradient of 80 millimeters of mercury down to a provocable gradient of less than 10 after a successful single ablation. So clearly, this is a guy who had a good result following an indicated procedure. We tend to be hammers sometimes with nails, and so if somebody comes back with chest pain, then the immediate first thought is, well, we have to do an angiogram again, right? And sometimes it's more than just an angiogram. So he'd had a symptomatic episode of VT, had an ICD, and then he comes back with shortness of breath that was slowly worsening. A repeat echo from an outside cardiologist showed a new LVOT gradient of 40, up to 60 with Valsalva. And he was referred at the time for repeat septal ablation, even though we hadn't really done the echo ourselves. And one of the things that we do at our center is specialize in hypertrophic cardiomyopathy. So this is the baseline angiogram that he had come with prior, right? You can see that really large S1 that was the target for his septal ablation the first time. This is the RCA. Oops, sorry. Okay, and this is the original septal ablation procedure. Wire into the septal, balloon goes up, alcohol ablation through the inflated balloon through a variety of accesses, and things went very well. right? We were quite pleased with that. So when bringing him back, expecting to have to re-ablate at least a part of his septum, we went in with the appropriate accesses ready to do what we needed to do. We had a left femoral venous line that was a 7 French for a Swan-Ganz catheter to determine the cardiac output. We had a left femoral arterial access with a 5 French end-hole pigtail in the LV so that we could get a constant LV pressure. And then we had the right femoral artery that we expected to use for our procedure, right? The one end of the pigtail was connected to one transducer, and then the sheath in the femoral was connected as the aortic pressure to the other transducer, sort of a quick and dirty way because we didn't have a Langston catheter available at the time. So there's our initial hemodynamics, right? Very nice aortic pressure on top of an LV pressure. There's nothing particularly special here. And then we induce a PVC to look for a Brockenrow-Brunwald-Morrow's sign of post-PVC augmentation, and what do we see? Nothing, right? It looks pretty good. So we probably should have repeated that echo before we took him onto the table, but we believed the pictures that we saw, and we tested the hemodynamics, and there really wasn't anything around. So there was no gradient with provoked PVCs, there was no gradient with Valsalva. We repeated the echo on the table, there was no real gradient appreciated there. So maybe his heart was hyperdynamic at the time, maybe he was unwell, maybe he was very dry, who knows, right? And so we figured, well, okay, he's here for shortness of breath anyway, it's just a diagnostic, we'll quickly shoot the coronaries, get in, get out. So we took the pigtail out, we exchanged it for a JL diagnostic catheter, recognizing that we still had the right groin access that was available, but decided not to use that for whatever reason. And then when we put the JL in, our usual practice is, in usual and interventional cardiology, we're always trying to fix safety, right? So you bleed back the catheter to make sure you have flow. One of the things that I do when we engage anything is I actually have a little 10 cc syringe on the table and I suck back because I don't, on the off chance that I'm not getting flow backwards, I don't want to move the catheter without negative pressure on the end in case that is indeed a thrombus. Because if I move the catheter with the negative pressure on the end and it's a thrombus, I can at minimum pull it out of the heart and out of the way of the head and neck vessels so that we can deal with it. So we did not inject through the catheter. But very shortly after engaging the catheter, not being able to suck back, this was the pressure. So you can see this sort of terrible looking sail ST segments across the ECG with this dramatic drop in his blood pressure to a systolic of about 65. So what's the problem? Right? This is not a difficult thing to surmise. We've either dissected the left main or thrombosed the left main. So he starts complaining of severe chest pain, immediately take the JL out, flush the sheath, drop 10,000 of heparin in, go in with an EBU guide with the expectation of fixing something. And now he becomes unresponsive. So now we have a big problem, right? You can see that there's no pulsatility left in that art line tracing on either side. And so now we've decided, forget fixing the left main, we need to get him onto some sort of hemodynamic support to manage his cardiac arrest and then deal. This was all a witnessed phenomenon. So this is his first angiogram. So that is not a happy heart, right? There's a big, giant, ugly thrombus sitting in the left main. Clearly was attached, a tubular thrombus, probably picked up from the sheath attached to the JL catheter that just moved right off of the catheter as we pulled. So we quickly placed a wire down the LAD. At the same time, the contralateral access on the other side was upsized for support placement, started CPR, started cardioversion for VFib 3 times, and then addressed the left main as quickly as possible. We had an impella that was easily set up in our lab. We had already called for the perfusionist because we expected we would need ECMO, but that was going to take some time to prime the pump. So we quickly put in an impella and did several runs of aspiration thrombectomy in the left main and LAD. And this was after that. So this is better. There's flow now down the left system. You can see that the heart is beating. That is clearly an improvement from where we were before, so we're winning. But the circ is out. So after we put in the impella and the aspiration, he still remains very, very sick. He's still not doing very, very well. So at this point, the decision is made, now that the perfusionist has arrived, to stop the intervention further because now we've only been about 30 minutes in. So that circ is still a viable territory. Let's get this person on hemodynamic support beyond the impella, right? This is somebody who's got effectively no functioning heart output, so he's a classical patient for ECMO. And so we quickly cannulated the patient for ECMO. And I mean, we've always talked about what happens in PCI, right? Emergency PCI is fun. Complex PCI is fun. Emergency complex PCI can get kind of dicey. So in this case, the access was done as quickly as possible. A Lunderquist wire was used because this man is not a small man, and so we needed a relatively supportive wire to place the 21 French ECMO cannula in his left common femoral vein, or his left common femoral artery, because this was a large man, so he needed full arterial access. And then radial access was obtained to be able to do the procedure. So we gave up the femoral wire position, 21 French arterial in the left groin, 25 in the venous in the right. And there we go. We don't have much in the way of pulsatility, but we do have a mean arterial pressure of 100. And his STs are now starting to come down because we've unloaded his heart. So his oxygen demand has come down very nicely. So we quickly check the RCA from the radial route. The impella is now at minimum just to vent him. And then we turn our attention back to the left system. Okay, and we address all of that thrombus. We end up rewiring, doing thrombosuction and rheolytic thrombectomy, so angiojet of the circumflex system into the left main. The angiojet, I don't know, for those of you who are not familiar with it, is a rheolytic thrombectomy system where it basically sprays blood at a thrombus, pulverizes, and then quickly sucks it back into the catheter. So it almost sounds like a washing machine where it's back and forth, but it removes the thrombus. And it's very effective in the legs. In the heart, it kind of comes with bradycardia from time to time, so you have to be careful, but in this case, we're on ECMO, so we don't care. And we actually managed to get a lot of flow back, right? So now the circ is starting to open up, the LAD is starting to open up, we're doing much, much better. And this is what I thought of myself at the time. I'm awesome, right? I've saved this man's life, I've pulled him out of the fire, I'm feeling really, really good, and then there is badness. We all know that the battle is won and lost at the access, and so he starts now profusely bleeding around the femoral sheath. This is the impella sheath. I look at the impella sheath carefully, and we see that there is a tear in the common femoral artery just above the impella sheath, partly because the sheath is a little bit cracked inside the common femoral. So this is not good now. We've lost at least 2 units of blood. His ECMO is now starting to chatter, right? So we start now transfusing him, praying that he's not going to thrombose his coronaries again. And then we check the heparin and realize that the heparin's only borderline, so we give him more heparin, which then makes his leg bleed some more. You see where this is going. And so after the cut down, where we get control of the left femoral bleed, we see this. We go, I don't understand. He's on ECMO and impella to vent the LV, and his coronaries are open. I literally looked at this man's groin and said, explain yourself. This doesn't make any sense, right? So we executed a massive resuscitation, several units of packed red cells, vasopressors, liters of fluid, etc., and then took some femoral arteriograms. So unfortunately, it says it can't play media here. What this demonstrated was that there was a little arterial injury, but it was fixed, okay? And then when we filled him up, right, we give him lots and lots and lots of blood, we actually started to get his pulsatility back. The ECMO started to support him again, right? So the issue here was we were out of volume, so we fixed the volume. But then he goes to the CCU and he does it again. And what's worse now, his bladder pressure goes up to 22. So he is developing an abdominal compartment syndrome. So we're asking ourselves now, where is this coming from? And we realize that we actually, when we put in the venous cannula for the ECMO, remember I had mentioned that there was a little bit of resistance and some concern about the wire position. Well, I tore his IVC with the ECMO cannula, right? So that's a frustrating situation. So we then got vascular surgery involved, did an emergent bedside laparotomy. Thankfully, there was an area of injury in the IVC that was covered with thrombus, and so he wasn't bleeding anymore. So we were able to close his belly. He had a large right-sided retroperitoneal hematoma that was treated conservatively at the time. So how do we get better from this, right? Like, what a train wreck. It's a disaster, all from a angiogram. So when we do systematic analysis, we do this in our cath labs, in our practices every day, right? We hold M&M rounds, for example, morbidity and mortality rounds. We hold case discussions. We hold seminars like these where we systematically analyze complications. Or where we analyze things, but there isn't really a good framework that we can use to analyze complications. So this is a framework that I came up with a while ago that I use in my own practice and something that we're writing up to publish. It's called the PETALS approach. Number one is, what is the predictability of the complication that you've had in the context of your case? So if you had a big perforation, did you have a giant calcified nodule that you didn't image, and so you then took a balloon up high, no surprise you perfed? Was it predictable? That's the data that we get from the big studies. E is the event prior to the event that caused the complication. So for this, it was, Why did I choose to do the angiogram when I had good evidence that the reason I came for was not the problem? Why did I do that? I'll be done in just 2 seconds here. T is the treatment that was employed and the outcome that was achieved, right? So this is just the usual stuff that we learn about. How do you deal with complication X or complication Y? A is the advice for your next case. So how do you change your environment? How do you change the cath lab to systematically prevent one or several of these complications? For example, micropuncture access using an ultrasound, even in emergencies, to make sure that your femoral artery doesn't tear. You know, making sure you see the end of a wire on fluoroscopy at all times, particularly if it's a stiff wire, so you don't tear the IVC. L is the life lesson learned. What am I going to do to change my practice to make this better? That was the last time I ever did a, quote, unnecessary, left coronary system shot while I happened to be in there for another reason, because this is what can happen. And then S is important. This is the support of your peers. This is peer review. This is where you have to take this case and you have to be able to be honest about the complication you've had. Discuss it with your peers and figure out if they have any ideas of how to make their own practice better, as well as yours. That's a really important piece to this. And so my Pedal's analysis of this was not predictable. It was unexpected. We didn't know this, right? It was probably from the sheath. The event, before the event I was still trying to figure out why the echo had a gradient from outside and we had no gradient here. So I wasn't paying attention to the switch over to the coronary intervention. And so when my fellow then put a diagnostic catheter up, I didn't watch him. That's on me. It's my patient. It's my case. The treatment was Impella early, ECMO early. Both were good decisions, right? Aggressive resuscitation, calling anesthesia, calling the people from the CCU to help with the resuscitation. Again, good decisions. But vascular access could have been done differently. And as a result, we have changed the way we do vascular access, whether it's an emergency or not. A, always, 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 always flush the sheath, right? We've changed the scrub tech protocol now so that there are always saline injections on top of the patient so that you never have to reach back far. It becomes a procedural memory thing to make sure the sheaths are clear every time a catheter is exchanged. Your L, your life lesson is never lose focus. Don't ever let anybody interrupt you. If you're in the middle of an acute resuscitation, get someone else, one of your partners, into the room and get them to scrub so they can stand beside you. So that even if they're there for moral support, they're keeping their eye on these little things so that you don't have to. You can think about the bigger picture. And then S is, of course, I called for help, right? I called my CV surgical partners. I called all of these people in. I called the vascular surgeons to do the cut down. And when we were done, their response was, I'm glad you called. This brought us closer as a team because ultimately, this guy got better. He came off after 4 days from ECMO. His mental status returned to normal. He was discharged 3 weeks later with a completely normal EF, and he walked into clinic a month later. So crash and burn it's a difficult experience for anybody. But ultimately, if you use a systematic approach to analyze your complications, you end up a better operator because of them. The only way to avoid these things is to not do cases, right? And that's just not what we do. Thanks very much.
Thank you, Sanjog. Excellent case, excellent management, also excellent presentation. Dr. Sanjog, please stay here. Please.
Kalra, can
please sit down.
One or two clarifications. If I understood you correctly, you took the patient for a cardiac cath second time with the information given to you that there was a gradient of 60 millimeters of mercury.
Yeah, so we had successfully ablated his septum and then brought him back for this purpose, yes.
So who did the echo and why? How did you find out the gradient of 60?
Good question. So this is the whole point of the case, right?
That's ridiculous.
It's ridiculous. That's ridiculous.
Because
So
if somebody had told you that there is no gradient, why would you have taken the patient for a second cath?
Yeah, so the gradient that we produced after our intervention was resolved. But then the patient, after a year, presented with symptoms again. That echo was done outside. That echo demonstrated a new gradient. So the concern was that there was either something we missed or there was a recurrence of some of the hypertrophy, and as a result, there was a gradient that was back. Our error was we did not repeat the echo before putting the patient back on the table. That was the problem.
Secondly, you said the thrombus might have come from the sheath. Which sheath?
So the left common femoral arterial sheath was a 6 French sheath.
How did it go into the coronary?
Because we took a 5 French catheter out, which was the pigtail, and we put a 6 French diagnostic catheter
On
in.
the same wire you put a 6 French.
Correct. So usually when you take the catheter out, you would flush the sheath.
Out and put a new catheter over a new wire.
Yeah. So no, that I disagree with. If you have a J wire in a femoral sheath, you take your pigtail out. Your J wire sits there. You take a saline flush. You suck back on the sheath and you flush the sheath so that if there's any thrombus, you've cleared it. Or if you can't suck back, that's when you know there's layered thrombus on the inside of the sheath. You remove that sheath, you put a new one in. But you don't take the wire out, right? So in this situation, we left the wire where it was, but neglected to, and as I said, I was trying to figure out the gradient, we neglected to clear the sheath.
My question was that since you, after doing the left heart study, you did not find any gradient between the aorta and the left ventricular pressure. Now, your job is finished. That means this patient does not have any recurrence.
Yeah.
Pull out your pigtail.
Yeah.
Now you want to see a coronary again. Because after all, something is there, patient is complaining of breathlessness.
Yep.
So you put a Judkins and on a new wire and take the coronary angiogram. Why do you have to keep the wire there?
Yeah, I mean, I think the same.
J-shaped wire, why it should be kept there?
Yeah, I think we're not talking about the coronary wire. We're talking about the J wire in the sheath, right? So the coronary wire is long out. There is no coronary wire on this part of it, right? You've just put your pigtail and you've tested your gradient, right? So you just take your pigtail out, right? You don't just pull a pigtail out. You put a wire through it and you back the pigtail out so that you don't injure the sides of the aorta, right? So we're not talking about the coronary wire. We're talking about the J wire that's inside the 6 French sheath in the leg. That's not something you would typically, you don't change the wire or take everything out every time you go from a JL to a JR, right? That was just a normal exchange, right? There was nothing unusual about that exchange. The problem was that we didn't flush the sheath. There was no coronary wire in the second case because you don't need one to test for a gradient. All you do is go across with the pigtail and then you provoke a PVC and you measure the pressure between the femoral sheath and the end of the pigtail, right? So there was no gradient there. Ultimately, the decision to go ahead with the angiogram, I think, was reasonable because the patient has symptoms, right? The problem was that in the midst of the first part of the procedure, because it was an unplanned exchange to a second part, right? We weren't expecting to have to do a coronary intervention per se unless we did an ablation again. We weren't thinking about that as part of the procedure at that stage. I was still focused on why the hell I took the patient on the table instead of doing another echo.
How long back was this procedure done?
Oh, geez, years.
This?
Years ago.
Year ago?
Yeah, years ago.
Thank you, sir. Thank
I
you.
did my first Hocum septal ablation way back in 1999.
Yeah.
And I killed the patient. I am so sorry. There was a lot of people around me and we were new to that technique. And we put a, over the wire balloon into the septal. Technique was not very well developed at that time. Someone said, pull the catheter a little bit back. Someone saying, push it further back.
Yeah.
So in that context of confusion, when we injected the alcohol,
it went back into the
spilled
LAD.
back into the coronary and everything got thrombosed.
That's the most feared complication. For what it's worth in those, you turn up I usually use a 1.5 or 1.25 OTW balloon, put it into the septal, and then I always inject contrast through it and look for the contrast to be trapped. If there's any reflux of contrast, you're in trouble. So now you take it down.
Thank you, sir.
Yeah.
Sir, we should arrange for
I
time.
just on comment regarding the LVOT gradient. I used to do some septal ablation. Lot of case comes from outside. With echo, LVOT gradient is 70, 80 like that. When I repeat the echo by the expert one, gradient is 20. So on factor related, there may be mild MR, and then that MR jet sometimes misnomously that is calculated as LVOT gradient.
Yes.
Yeah. Particularly when you have a hyperdynamic heart and a dry patient. Totally.
Dr. Sanjay Karla will leave now, I think, Bangladesh, Dhaka.
Thank you.
Madam, give the memento. Dr. Sanjay Karla. Sanjay Karla always great friend of Bangladesh. They have, I think, third consecutive visit in Bangladesh this year. Second consecutive visit. Yeah, this year, a second. Dr. D.S. Gambhir, I think, is life-threatening left main coronary dissection. Professor D.S. Gambhir. Professor, yes, I think 2 cases, I think so. Also another, my worst challenging case of root ablation.
Well, friends, when you plan your journey, most of the time you think that the journey is going to be very smooth, but that's not always the case. And sometimes there may be upheavals, there may be roadblocks, there may be moments of joy for you, and there are moments of disappointments. So, but there is always a light at the end of the tunnel. What I'm going to show you a case which is looks very benign, and I'm sure many of you, when you see the first angiogram, may feel that why I'm showing this case. But this took 3 hours to complete this case. This is a middle-aged lady, 68 years, diabetic, hypertensive. She had undergone a previous PCI in 2008 and then again in 2019. 2019, she had a stent put somewhere in South India. Then few months later, she came in 2020 and angiogram was done in another city where they found that there was an intrastent restenosis in the circumflex artery. So it is presumed that she must have had undergone a stenting in 2019 in the circumflex. Now, this second place where she had gone this time in Mysore, the interventionist just did a POBA of the circumflex and left the patient. Patient was all right for 3 months, and then she returned with angina on exertion, and that's the time when she came to us. Now, this was her angiogram. The right was more or less okay. Many of you might see that this is a normal angiogram, but this is not so. She was very symptomatic, and you will have to believe me that when even going to the washroom, etc., she would become breathless and she would have some chest suffocation. There is a significant, there is a stent in the LCX right from its origin across the obtuse marginal one, and there is a sharp bend in the vessel over there, and there is a moderate degree of intrastent restenosis over there. We also, looking at this angiogram, thought that this is a very simple case and we should be able to finish it in half an hour. So the initial strategy was to balloon it with a non-compliant balloon, and if that doesn't work, then a cutting balloon would be able to do the job. And if that does not work, then we thought we should do a rotablation, and further treatment would depend upon what do we get after rotablation. So we put a NC balloon and we were unable to open up this lesion. You can see that there is a big waste on the balloon, and after the balloon, the lesion remains as it is. So this is what you can see, that we put another balloon, 2.5 millimeter now, and you can see a tight waist on the balloon. So at this point of time, we thought that we have to move forward and we should change our strategy from balloons to stents, from balloons to rotablation. So we crossed this lesion with a rota wire. Now the next problem was that even the smallest bar of 1.25 millimeter bar would not cross this lesion. You can see that when I am trying to cross this stenosis, and particularly the bend, the lesion would get stuck up at the bend, and the guiding had a tendency to fall down. This process continued for almost about 10 minutes and we were unsuccessful. And now you see that the tip of the wire, just keep your attention on the tip of the wire, rota wire. In the left-hand side screen, cine angiogram, the tip of the wire is in the anterior branch. And then we thought that let's do some trick here. We changed the tip of the wire with a Dynaglide mode into the posterior branch. And having done that, oh my God. Once we did that, the first problem we came across was that the burr got stuck. You can see that burr is entrapped into the lesion, and this was a major problem for us. Now, we were a little taken aback, and then we tried our best to pull this burr. This is the usual practice, that you have to keep a constant traction on the burr. But we were fortunate that after giving some nitroglycerin, patient was stable, the burr came out, and along with that came out the wire. So we were successful in disengaging this burr, and then we thought we have to make a second attempt to negotiate the rota burr. So we again placed the wire rota wire and again into the anterior branch, but the burr would again not cross. So we thought that let's change the wire again into the posterior branch and try once again what happens. By changing the direction of the wire, this time the burr crossed. So a little trick that changed the bias of the guide wire allowed this burr to get down into the bend, and the ablation was successful at this time. But then the story doesn't end here. So this is the post-rota balloon was done, and you can see the balloon is still showing the same base as what we had seen at the beginning of the year. So at this point in time, we had passed a second wire also to see that if we can crack this waist, but that would not help. So we upsized the burr to 1.5 mm burr, but that did not have much problem. So we were able to pass a 1.5 mm burr and rota ablate the proximal LCX and also go into the obtuse marginal branch too. After this, we put a high pressure NC balloon, and the proximal lesion gave way, and the waist disappeared. So you can now see that there are 3 wires, 2 in the posterior branch and 1 in the anterior branch. Why in the anterior branch? Because we thought we will do a burring of the rota of the anterior branch also. But before that, you can see here that once we were trying to open up the second lesion in the circumflex after the bend, the waist was still there. The proximal lesion had opened up, but the second part was still undilatable. So at that point of time, we thought we should attempt to open up the OM branch first. So we passed a rota wire there and pulled out the other. First we passed a wire, ordinary wire, and tried to open it up with a balloon. But again the same problem started. The OM branch would not yield. Then this is the stenosis persisting in the OM branch. And then we thought we should do a rota even in the obtuse marginal branch. But again the same problem. The burr would go down and it got somewhere stuck here, and it would not enter into the second branch. So while making second or third attempt, the wire broke down. And now once the wire broke down, I don't have that frame. You can see here the wire is broken, the distal tip of the wire is broken, and we were fortunate the burr went into the posterior branch, and we just noticed that the burr is moving without the wire. So, of course, the wire had broken. That was not a worry. So, we pulled out the rota without any problem. Now, you can see there is a wire tip which is broken into the anterior branch, and the burr has come out. So, we were at square one once again without having dilated the obtuse marginal posterior branch and also the obtuse marginal one. So, we wired once again all these branches once again, and I'll just go. So then what we did was that by this time 2 hours have passed on. So what next? What were the possible options? Either we had abandoned the procedure or use a body guide wire to negotiate a desk, because the drug-eluting stents were not going now. So we used a guide extension and changed the guiding to AL2. But the option second and third, that is a body guide wire and the guide extension would not even enter into the circumflex. So we changed the guiding to a M+2 guiding catheter. And having changed the M+2, we again have to wire it, and then we were able to pass a stent down. And this led to the opening up of the first lesion, but we are still left with the second part of the stenosis, which is beyond the obtuse marginal one. So this was the result after this. We then had to deploy a second stent. But there was not much of a problem in negotiating a second stent 2.5 into 28 beyond the first stent, which went on easily, and we opened up the second stent. But after, you can see that there is a significant residual stenosis still persisting over there, and repeated balloon dilatations failed to open up this. So, residual stenosis persists in the distal LCX, you can see just after the obtuse marginal branch, and if you see the balloon in the right hand side, there is still a significant waste. So at this point in time, we placed firstly one body guide wire, that did not help, and then we put two body guide wires. You can see that there are 3 wires in this posterior branch and one which is a broken wire in the obtuse marginal one. And at this point of time, we continue to give high pressure and suddenly the waste disappeared. I don't think we can show you that. And finally, the stent expanded. So then we had a sigh of relief. We were able to restore a good lumen both in the proximal as well as in the second part of this LCX OM. And this was the final result. And this was follow-up after 4 weeks. The patient was called back to see that the obtuse marginal branch, there has been no thrombosis, etc. So that was patent. So, friends, instant restenosis is sometimes a very difficult problem to treat. We started with a moderate degree of instant restenosis and ended up in almost every complication, starting with stuck burr, then the guide wire of the rota wire got broken up. The lesion would not yield. We had to put a buddy wire. We had to change the guiding catheter to Amplas guiding catheter, and 2 buddy guide wires had to be put. So many things have to be done to finally achieve this result. So I think in the end, I would like to say that when you come across this kind of problem, keep your patience, do not lose concentration, continue to work. Don't get frustrated at failures, because we had spent almost 3 hours on this patient, and continue efforts hoping for success, which means there is always a light at the end of the tunnel. Thank you very much.
Thank you, sir. Your perseverance, sir, against the battling against the calcium. Any comments for the senior teacher here? Dedication make the success. I think use calcium, complex calcium. Ashudatto, any comments?
Actually, this is the one of the example how 1500 rotablation in one hand can be done. So this is the perseverance. So I have one question. How much time did you spend for this patient in the cath lab? Number one. Second, how much time did you spend outside the cath lab to think about the next processing or next setup of management of this patient? So
now, inside the cath lab, we spent almost 3 hours.
Outside the cath lab?
Outside the cath lab, once the procedure was successful and the angiographic result was good.
No, for this case, for the next time, how did you just...
No, next time may not always be a similar
no,
problem.
Sometimes someone just think prior to that night, before
I think
the
the
procedure.
lesson that I have learned from this case was, that's what is the question, that lesson that I learned from this case was two things which we possibly missed. One was instant restenosis is not always easy to treat. That's one. So be prepared for all hardwares that should be in your pocket, and that may have to be used one after the other. Yes. Second thing is bend within the instant restenosis is the worst thing. And this is the bend which led to all these problems. Because the burr was not going because of the intrastent restenosis, which could have been even a fibrotic also, which could have been even a calcified also, we don't know. But the bend was the main important culprit thing. Third thing is, you should be well versed with few new tricks literature, like buddy guide wires, 2 buddy guide wires. I had never thought of it, but I mean, just idea came to my mind that why not to put an additional wire. I was going to put a 4th wire. But after putting 3 wires, the lesion gave way. And so I think then we started using this as a technique. And out of 3 patients like this, 2 we were able to open with 2 buddy guide wires, and the 3rd one did not yield even with the 3 buddy wires.
Thank you, sir. Thank you.
Sir.
Great case,
next case.
Dr. Mohsin, I just have a question to Dr. Gambhir.
Sure,
Thank you, sir, for your very bailout procedure. Actually, regarding the broken wire, did you make any change to the post-procedural antiplatelet regime, or did you have to add any anticoagulation? Actually,
No. Let me tell you honestly, we have been doing rota since 1991, and I was a proctor for rota and one of the first one in the country to do. By this time, I must have broken the tip of the rota wire at least in 8 to 10 patients. And all are doing fine. We give antiplatelet agents to all of them, but most of the time the rota wire gets broken between the radio opaque and the radiolucent portion because that junction is weak. Now, why it broke down over here, I will tell you the reason. Because when we were trying to negotiate the burr across that bend into the obtuse marginal one, the wire was not deep in, and at that point the burr possibly hit at the junction and broke the wire. Wire went ahead and the burr slipped down into the obtuse marginal 2. So we have to be careful not to do a rota near the junction or on the junction or on the radio opaque portion of the wire. But nothing happens. The antiplatelet regime remained the same, and 1 week later the patient was doing fine.
So one take-home message we can take from here, that the middle-aged ladies should be dealt with caution in the cath lab and every aspect of life. Thank you, sir.
Why middle-aged? All ladies should be held with caution in the lab.
Thank you, sir. Thank you. Next case, Professor Ashok Kumar Datto.
Respected teachers and my dear audience, my case is not so complex and mastering, but for the fellows, there is some learning that I have learned from my what Dr. Shangjug was telling, LLL, live lesson learning, means lesson that I have got from my lifetime experience. So this was a 45 years old man having recurrent episode of unstable angina. There was STT change on the anterior lid, anterior wall hypokinesia on echocardiogram, ejection fraction around 50%. Smoker, hypertensive. Elective angiogram shows there is lesion in the mid LAD, and patient was very much symptomatic. Class 2, class 3 angina on E4. Before that, he had unstable angina, acute coronary episode. So this was case of spontaneous coronary artery dissection, possibly repeated attack of spontaneous coronary artery dissection. And that is a very old case. Around 10 years back I did it, and since then I have stopped doing PCI to the SCAT case. So this is relative contraindication of even in acute coronary setting to do the PCI to the spontaneous coronary artery dissection. Because most of the cases that does not need stenting, spontaneously that heals without an effect. So without any thinking, that was an ad hoc case. So without any thinking, after wiring, I feel resistance after causing the lesion in the distal LAD. Tip was not moving. So I feel there is something wrong. And patient start complaining of chest pain. I pull out the wire, and there is restriction in the flow to the distal LAD, and that dissection become obvious. So that is done by the wire, not in the true lumen, in the subintima. So there was some STT change. I took a microcatheter with pilot wire. I think that will negotiate the lumen, and it goes distally. Initially, I put the wire to the septals. So that's initially, I think that is the true lumen. So I progress it more distally. On the left side, that was in the septal. So push the microcatheter and remove the wire, and through the microcatheter, find cross. Distal lumen was ensured with tip injection. Patient developed bradycardia, hypotension, close to the LAD, totally lost. So this is the point where there is no way to return back. So I did the balloon dilatation because distal part I know that it is in the lumen. In the mid part, that is the subintima. So subintima to lumen, the wire has crossed. So I did the pre-dilatation with a smaller, then progressively with a bigger balloon. All the septal branch in the mid and part of the distal LED is lost. All the septal is lost. You think that is totally bald area in the mid LED. There was a lot of septum initially, if you see. So all are lost. Patient, after giving IV inotropes, developed tachycardia, still hypotensive. I put a stent there, do the post-dilatation. So giving the distal flow is better, but by this time anteroseptal MI developed because of loss of septal in the mid and proximal LED. So patient was subsequently managed conservatively, rejection fraction reduced to 40%. And chest pain subsequently subside, possibly because of MI, all the muscles lost. So there is no area for ischemia. So this is the experience that was around 10 years back. Till then, I always tell my fellow, I always tell my juniors, for SCAT patient, don't do anything. So another case, just it is done last week. That was a 65 years old male patient. Having history of 6 sinus syndrome, unstable angina. That was the angiogram that shows right coronary is very small, left dominant, severe left main disease. He was the relative of one of our doctor who worked in cardiac surgery. So there is a tight lesion in the LCX, dominant LCX. So when it was explained that you need something, either surgery or PCI, he was thinking and he was taking time that he will talk with his senior surgeons. He knows that as per new guideline, he knows, he was talking about that, new guideline, surgery is the better option. So I will do the surgery and I will talk my senior surgeons. Patient was waiting. I was trying to tell him better to do at least, because that time patient was all right. But while we are discussing with the doctor's relative, patient suddenly developed bradycardia, asystole, and hypertension. So from waiting room, suddenly patient brought back into the cath lab with CPR ongoing. That is the last year's scenario. Heart is totally stopped. I put that temporary pacemaker. CPR was going. So luckily wire went into one of the branch. Then pre-dilatation with 2O balloon, that was a new balloon. CPR continued. So with CPR, intracoronary adrenaline stent deployed 4 into 12 millimeter DES. Heart was barely moving here. Patient, by this time, our senior anesthetist was there and he intubated the patient. So after post-dilatation with 4.5 millimeter NC balloon, heart started contracting. So LC acceleration, I kept it like this. Patient survived. And before discharging the patient, I did the LCX stenting. And that was a very tortuous, with the help of body wire, I put the stent, 4 millimeter stent, 4 into 24. Post-dilatation, the patient discharged after just 5 or 7 days. So this is the final result. Thank you for patient hearing.
Thank you, Professor Abdullah. The excellent case. We are moving forward because short of time. Dr. Vijay Dotto, a journey through a reserve road. Dr. Vijay Dotto.
Respected chairperson, panelist, and my dear colleagues, after such a beautiful presentations by the legends, I am little bit nervous to present my case here. So my topic is a journey through a reverse route. This is a 60 years male hailing from Chatpur with ongoing chest pain for 4 days, and he was admitted in a private hospital where I routinely practiced, and on admission, his pulse was 124 beats per minute and blood pressure was 110/70. He had a history of COVID 3 months back, and he had the same type of chest pain 1 year back. And for the last 1 year, patient complains of ongoing chest pain, that is CCS class 3. And his ECG shows that is oldema inferior with features of dextrocardia, and the X-ray shows this dextrocardia, right-sided aortic arch with fundic gap shadow in the right side. So most probably this is a case of, and his echocardiography of just a few months back shows the dextrocardia inferior hypocondition is good, and is a mild LV systolic dysfunction that is 46%. So troponin was raised, and he has already a previous ultrasound which shows the situs inversus, that is everything is in the reverse side. So my diagnosis was non-ischemic with refractory angina. That patient was ongoing chest pain with maximum medication, and oldema inferior, and mirror image dextrocardia with situs inversus. So ACC AHA guideline 2021, according to the guidelines of non-ischemic, it shows that if the patient is cardiogenic shock or refractory angina or hemodynamic instability or electrical instability, we must have to do the invasive strategy within 2 hours or as soon as possible. So but the problem is, we are doing, I doing my evening practice or in a center that where this is the angiogram machine is in the older version. There is no IVAS, FFR or guide catheter, route is unknown, there is ongoing chest pain, but we cannot wait. Look, the entry of the catheter, coronary catheter over the guide wire, that is from the right side, sorry. In the left panel, in the right panel, look, this is RCA or left system. This epicranial view shows the LED is 90% occluded in the stenosis in the proximal part. This is spider view, epicaudal view, showing the same. And LEO view for the RCA shows that there is complete occlusion of the distal part of the RCA. So it is a case of mirror image dextrocardia, right-sided aortic arch, RCA CTO with multivessel disease. I have experienced only 4 cases of dextrocardia in my 12 years of interventional cardiology career, but I have no experience on dextrocardia PCI previously. And my cath labs team have no experience of handling such cases of dextrocardia PCI. So this is the great problem for me. And for this, I am little bit nervous for that, but I cannot avoid saving a life. So for this issue, I discussed with their relatives, because this is a patient of non-STMI with LED 90% and RCA CTO. According to the guideline, I want to fix the LED first, pre-dilated stent was positioned, stent deployed, and after that 3 into 12 NC balloon was dilated, and this is the final view of this. You can appreciate the result. But after that, when I tried to complete my procedure, the party came to me that, sir, please complete the RCA also. I repeatedly denied to do that because this is a CTO, I think this is a CTO. But they are thinking that as most of our patients, they have a low budget and they are trying to, they are finishing this second work within this budget. So again, I tried to negotiate the wire. My workhorse wire would run through floppy wire with a balloon support, but failed. Then I changed to pilot 150 and again tried many times, failed. Then tried with pilot 250, tried for another 30 minutes. 2 hours already passed. We failed to ensure the integrate flow in the RCA. Finally, wire exchange with Fielder XT with balloon support. And he still could not find the integrate flow. In this time, patient complaining of chest pain, pulse, rapid thread and BP, his vitals are going down, there is crepes, high flow oxygen injection, fusamide, and injection already started. I again checked for any dissection or perforation or any thrombus. And look, there is a white shadow in the proximal part of the RCA. And ACT checked, and it was less than 180 seconds. And IV heparin and intercoronary bolus in FT heparin was given. And we are waiting for stabilizing the patient. Sometimes we may or may not reach our target with maximum efforts. And after waiting for the procedure, finally, after stabilizing of the patient, I crossed the ablation finally and tried another 1 hour and finally crossed with Fielder XT. And serial ballooning with 1.5 into 12 and then 2 into 15 millimeter uncompliant balloon. Drug-eluting stent was implanted. And this is the final view. Finally, I took breath. Now, tips and tricks of the mirror image dextrocardia offers a technical challenge to the intervention cardiologist due to its abnormal anatomical position of the heart. Sometimes right position of the right, that is right sided aortic arch, unfamiliar coronary anatomy, especially at their origin. Horizontal axis double inversion technique was developed for image acquisition. A mirror image between LAO and RAO using an image reversal technology will give an advantage to the operator for the intervention. RCA was engaged using an opposite maneuver. The important tricks is that we have to torque the RCA with the opposite technique, that's in the anti-clockwise, with the tip of the catheter pointing leftwards and rotated counterclockwise instead of rotating clockwise. This is the main tricks. Transfemoral access gives a better access, even though some reports of transradial approach are also good for dextrocardia cases. In cases with an isolated right aortic arch, a left Judkins catheter can be used for selectively cannulate the left coronary artery and is also able to cannulate a right-sided coronary artery. But in this case, I am fortunate enough to cannulate the RCA with the right Judkins in this case. The take-home message is the incidence rate of mirror image dextrocardia in the general population is estimated at 1 per 8,000 to 1 per 25,000 of population. Interventional cardiologists may have to handle such type of cases, as this is not so rare. Knowledge regarding anatomical orientation, image acquisition, torquing direction, guide catheter selection and direction, wire escalation can help to overcome the challenges. Thank you for patient hearing.
Thank you, Dr. Vijay. I think excellent manage before not PB has exposed this situation. Dr. Ashudotto, any just one comments? Yeah.
Just you can make the machine mirror image, so that will helpful to do the procedure.
Yeah, I have already mentioned that the machine was 2004 or 2005 version, and it was in a pipe, and it has no inversion technology.
Other thing, RCA was CTO.
Yes.
The culprit lesion was LED.
Yes.
So why the patient developed hypotension when you are doing the RCA?
There is thrombus for that. And ACT was less than 180. I will check the ACT. And after reversion of the ACT, that it was corrected.
You show the EKG.
Dr. Vijay? Yeah.
Where was the thrombus? You said there was a thrombus. Sir. Where did the thrombus form? In the left main?
No, sir. In the RCA.
RCA. But RCA was CTO. How does it matter?
Sir, actually, we thought that ACT was 180. Because it takes longer time, and we did not check the ACT. And when the patient is feeling the chest pain, we check for any dissection or for any perforations. And then we found that there is a whitish lesion in the proximal part of the ACT, the proximal part of the RCA. Then we checked the ACT, and we found that this is 180.
Okay, but then you continued with the CTO in the same stage.
We stabilize the patient. Sir. We stabilize the patient as we have already passed the wire.
Hey.
And we stabilize the patient for Mike.
Hey, EKG, show karo.
ECG check to the ECG.
The wire had already crossed the CTO.
Sir.
Then you found thrombus over there.
Sir,
Okay.
when we are manipulating the to cross the CTO lesion, then we found that.
No, the point that I am trying to find out, and I would like to emphasize, is that you see, in a CTO, when you have done left-sided vessels very well, patient had developed hypotension, patient has CTO in the right coronary artery, you have still not crossed it, you find a thrombus in the right coronary artery, you're giving eptifibatide, heparin. Now, during crossing of this CTO, suppose there's a perforation, she will then have serious complications. So, the advice is that when you have a problem like this, it's better to stop and hold on for a day or two, let her go through this crisis period, and then you can take her for a second stage for a CTO. CTO is never done under the care or under the guidance of these GP, 2B3 antagonists, because then if the patient has got a perforation, then you will have a tough time. Okay, thank you.
So, Vijay, guideline not always a guideline. You just guide you how to optimize your best result. Can you show the EKG? Right. Okay.
I am a bit confused whether this EKG is true dextrocardia or technical dextrocardia. Because in dextrocardia, definitively R wave height in the V5, V6 that is placed on the left.
Yes, I am completely agree. This does not match completely with the true dextrocardia.
Yes.
There's but 2, 3 NDVF, there is QF, 1 and ABL, the P is inverted, but the ABR is uprighted. ABR, P is positive in ABR. And there is tall R in V1. R is positive in V1, in right side leads. All criteria does not match.
Thank you, Vijay. I think nicely managed. Thank you. Congratulations, Vijay. Thank you so much. I'm requesting Dr. Anisul Lawal. He's from Chittagong. Please come on the dais. Is broken wire a friend? Dr. Anisul Lawal, please come on the dais and present your case.
So my first case, broken intercoronary wire. Mr. MC, diabetic, non-hypertensive, smoker. Presented with chest pain and diagnosed as acute STMI, thrombolized with STK, and he was presented with cardiogenic shock. ECG ST elevation in anteroseptal leads, and wall motion abnormality was there, 45%. And we have done angiogram, and also we have done the PCI also in the same sitting. This is angiogram, right side, there is no lesion. In his left side, we can see the lesion in the LAD, and there is also bifurcation lesion with the diagonal. So we go ahead with the PCI, and everything was going fine. He was hemodynamically stable, and we wired the lesion, and we put a wire in the diagonal, pre-dilate the lesion, and we optimize the lesion preparation, and we put the stent also. We put the stent up to the ostium of the LG. And what happened after the stent deployment? We feel that the wire is not coming out. Jailed wire. Jailed wire is not coming out. We try to take out it with a small balloon, but we are not able to negotiate the balloon up to that point. And we also try to do other maneuvers also, On that time, we don't have the microcatheter. We have the plan to go with the microcatheter, and we can go, so dilate and take out the wire. Patient is completely okay, is asymptomatic, and we are in a puzzling situation, what to do with this jail wire. So we talk with our colleagues and others. So everybody is saying, try to take it out, and if not, everything not works, gently try to remove the wire with a gentle traction. So with keeping the balloon proximally, I try to pull out gently, and it's broken. And through the stand bush, I found that the broken part is in the coronary, not in the left main. So I decided to leave the wire in such a condition and treat the patient conservatively. And the real problem started how to break the news. So everybody, the party came and I said, yeah, this is very fine. Only I didn't say that I put a wire there. And I shared this thing with my family. She said, you must say it very early. I said, I think I disclosed it before discharge. She said, no, you should immediately tell it. The next day, I called his patient's son, and I disclosed that this happened. Then many calls are now coming from Chittagong, Dhaka, everywhere. There is a broken wire, what to do? So this made me more panic. And I talked with Mirja sir and others. They said, okay, if the flow is all right, if the main vessel is okay, you can leave it there like this. And I go through the literature and found that, yes, this is potentially life-threatening condition. There may be ischemic event, there may be embolic event, even death could be death very rarely. But there are case reports where left alone wire is there, and then nothing happened actually. So we tell the patient everything about what might happen, and we keep in touch with the patient. He was clinically and symptomatically all right, and he was with our follow-up for last 1 year. And after 1 year, we had the plan to do his IVAS with the IVAS training by IPGI. He came, but there are many cases, that's why we couldn't do the IVAS, but we did his check angiogram. And check angiogram after 1 year shows this completely patterned stand and LAG, and the floating wire is hanging like before. So that's a great sight of relief. This time patient is from the hill tracts. He brings some mangoes and the lichus. I couldn't take this before doing his angio. After his angio, I was become free. Okay, this is my next case, Mr. MEU, 55 years, diabetic, hypertensive, ex-smoker. He has ST elevation, V1 to V4, echo, there is wall motion abnormality. Left main normal, LAG totally occluded, LCX non-dominant, RCA dominant vessels. This is his angio, right side is normal, left side total occlusion, and we take with the Fielder XT with the balloon support. We decided to go through PCI. So with the Fielder XT wire and balloon support, I crossed the lesion and started to pre-dilate the lesion. So everything is going fine. And after pre-dilatation, while I trying to pull back the balloon, I have a funny feeling that because balloon marker was there, but something is coming out. So I become puzzled. So what's happened? Balloon marker is there, but things are coming out. I immediately put the assembly forward. And I try to put the balloon marker as distal as possible. Yeah, I was able to possibly keep it in the distal part of the LAG. Yeah. Then what I did, I take another wire. I able to cross that wire beside this. And I take another small balloon distal to this. And I inflate the balloon. And I'm able to take out the whole assembly out. And after removing the whole assembly, I put the stand from the proximal LAG to the covering the lesion. And I post-dilate, optimized my result. And patient was hemodynamically all right. and there's the broken balloon after retrieval. And my last case, when balloon is stuck. This is inferior mite thrombolyzed patient, and after STK, sorry, this is single loop. We do the angio, and we found that there are lesion in the right coronary artery distally, and there is actually two lesions. One is distally and one is the middle part. So we pre-dilate the lesion, and we took actually there is a much healthy part in between. So what we did, we put a distal stand, smaller stand, and proximal one we covered with a big stand, covering there is a minor lesion in the up also. So after the deployment of stand, patient was hemodynamically all right. So we started the post-dilatation, first the distal stand, and then the proximal. And the trouble started when we do the post-dilatation of the proximal stand. We take a 4 balloon, that was a new balloon, but while post-dilated, operator said, the inflation device who is handling, he said there is some funny feelings, he cannot deflate it. Then all the panicky situations appears, patient suddenly deteriorates. We start CPR, we start putting temporary pacemaker, and then nothing works, we couldn't take it out. We try to make another deflate device to take it out. There are many things comes, whether we can other end of the where we can penetrate, but it is so distal the stand, we are afraid to do that. So finally what we did, I made a gentle traction. As you can see, the gentle traction may not be gentle enough, whole thing try to come out, but finally still settle. We intubate the patient, we put the patient in the ICU, and patient salvage. So my take-home message, challenging complex cases in resource-limited center needs logical approach, perseverance, and teamwork. Complication during PCI may appear anytime like tsunami, but can be managed by teamwork. And complication like tsunami, you need not only logical approach and teamwork, you need all the hardwares available, and you need prompt action. Thank you for your kind attention.
Thank you, Dr. Ganesh. Chittagong, the limited resource is doing excellent job. I think we move to the.
Anish, that broken wire, was it a new wire or a used wire?
Well, I thought it was a new wire, but later I came to know that was not a new.
That's the point. Whenever you use in the branch protection, use a new wire for the gel wire.
Yes.
You can put the used wire in the main branch, it will not stuck up, but that gets stuck up and get broken. And as because when we reuse it, during ETO it gets brittle. And the broken balloon?
Yeah, broken balloon, well,
also used.
Possibly used.
And it was broken at the junction where the wire comes out, monorail balloon.
Yeah.
And that is the point where it get broken, most of the time.
But sir, the stuck balloon, that was the last balloon, that was a new balloon, but it's still stuck.
Yes, your last
That
case.
may happen.
Your last case, you have shown very nicely with 3 challenging cases. Your last case, I want to share, Professor, probably my teacher, Professor Sufia Rahman, can memorize it in 2002. Inflating one stand, that stand balloon was not deflating. Stand balloon was not deflating. And patient, similar situation like you, hypotension, bradycardia. And what madam did, so far I can remember, she told it may be for different reasons. One reason is that dye may be more concentrated, and that is why she pulled slightly and with saline, push and pull, and this then this dye becomes diluted, and gradually balloon becomes disengaged and come out.
We tried to use that one with the diluting saline, but didn't work, sir.
By the stent balloon?
Same balloon.
Yes, stent balloon. And she, what I remember, she told that most likely it is one of the cause, the dye may be more concentrated, dye preparation is not well, so you pull and push, give saline, and this dye will be more diluted and slightly comes and slightly give forward with saline and come back, and gradually balloon becomes smaller and it came out. And besides this, we can do also with the opposite end of the wire, what you have tried. That we can also do. I think Madam will be able to tell it regarding it, many things.
I don't remember, but you remember. So many things happened in life when we started it. Sometimes balloon would not move, sometimes balloon would not deflate, sometimes you could not get rid of the stand out of the balloon. These are the problems we faced again and again when we started it, and I'm sure Dr. Gambhir also experienced it. So we learned it. If you cannot separate this tent and balloon, try it another wire, puncture the balloon, and then try to take out or rotate. But there's no shame in saying that every center in the world, they have used and reused it in the beginning, but they are not doing it now. So we are still doing it because we are poor country. Don't know.
That's down now.
Huh? No, I know some of the center, like here, like sometime you will need a long balloon or a very short chubby balloon you want, probably you'll find a old one is there. That's what I was trying to tell you before or also now, that check your equipment. Doesn't matter, you're using it, use it. If it is properly sterilized and there, you can use it. But most of the time, you are dependent on somebody on your right side, 1 or 2 or 3 sometime. They will, ji sir, Jan, madam, chalen, osubidha nai, kono osubidha nai, apnar hate eta hobe na, umker hate eta hobe na, doesn't matter how many cases you have done, maybe in 5 digit, 6 digit, doesn't matter. Complication will come suddenly. And you have to know how to deal with it. That is the main thing. So if there is any complication, you have to know that. So using right from the puncture, your guide, your wire, your balloon, these all when you put it, doesn't matter. I know the technicians get upset. Till today they get upset with me. So when they give me the balloon, I say, can I have a look? What size it is? I talk with them, and in the meantime I check them. Because I don't want to upset them, but they work with us. So that's why when you do that, I think, as I said, patient investigation, but your tools are very important. So there, mainly one important thing, if you want to wear a body wear, or if you want to gel it, and you have to make sure it is not coated one. Because if you pull it, the quotation and whole wire quotation may left in there. That will be a problem for you. So these are the things, small thing, but to avoid the complication, one can do it. In olden days, we used to have the balloon, they have cleaned it, but dye has not moved properly. So they said it's okay, and you cannot see with bare eye that the dye is there inside. So once you put the balloon and it doesn't inflate, it doesn't do anything, or sometimes they give full dye without dilution. These are the things, if you have your team, that is called teamwork. You have to rely on each other. Those who are doing shortcut, don't work with them or convince them to do it your way. So my number one is that if you are using it, take a diagnostic wire inside the bowl of saline and with heparinized water, guide, pass the wire and bring it back so that you know there is anything in there or not. This is very easy. But if is there something, you will feel it. When you are passing the wire and taking it out, you will feel some gritty sensation in your finger. So you know it is not clean inside. Number two, when you are using this PTCA wire, they're very important. You will find that there is some cracks here and there, you might see there it is, or bend. The bend situation, if you try to pass the balloon also damaged, and the wire may break if you force it. So there also, when they give the wire, you have a look, tip is okay, it's not broken, and the rest of it. Then the balloon, same thing. Can you inflate it? See, just friendly way. Don't irritate them because you need them, and you have to work with them. You have to rely on them, and they are your lifeline as well. So just tell them there, okay, can you inflate it? Let me see. and it's gone down. Make a habit of yourself so that you don't fall in trouble. And that's the way one can avoid it. But I'm not saying that you will not face it, but you will avoid it and you will have a less and less chance of having a complication. Okay? Thank you.
Thank you, madam.
Thank you, thank you. Anis,
Mr. Gambhir, you
nicely
have anything
managed.
to add?
Now, Dr. Abdul Momen.
Thank you. We are running short of time, so I'll be in a hurry. But I have few cases that are managed outside the cath lab. The complication managed mostly outside the cath lab, and some thought-provoking features in my cases. My first case, that drama beyond a successful intervention. The patient is a 40 years old, non-diabetic, normotensive, non-smoker male, chest discomfort and palpitation for 6 hours. He had a vaccination of third dose of COVID vaccine, Moderna vaccine. The first two was the AstraZeneca, 6 hours before. Troponin I was raised. Echocardiography, there is a wall motion abnormality, and this is the admission ECG. So some STT changes, but few PVC is there. And the PVC is continuing on the next morning. The patient admitted on the night, couplet, and we tried with amiodarone bolus, no response. Electrolytes were normal. Planned for early invasive strategy. And this is the angiography. The culprit probably the OM1, LCX also have minor disease, and LAD proximal also significant disease. So we stented the patient, first the OM and then the LAD, straightforward, and the patient was doing well, nothing. But during the procedure, the PVC is also continuing, occasional PVC. So the patient is doing well in the CCU. On the next day, he was shifted to the step down. This is after PCI. ECG is still PVC is there. PVC is continuing. And on the next day, for 24 hours after the PCI, the patient developed cardiac arrest. The monitor showed VT, immediate resuscitation done with DC cardioversion. Electrolytes were normal, and I was not there. The Professor Mir Jamaluddin sir was there, and I asked sir to check the angiograph whether we any occlusion of any vessel. This is post resuscitation ECG, and this is the angiography. The stents are fine. There is no lesion in the stent. So what might be the cause? And this is the echocardiography. My mysterious explanation is, could it be a vaccine-induced arrhythmia? There are several papers. These papers are of more than 1 crore patient with vaccine studied in UK, and they are studied both AstraZeneca, Pfizer, and Moderna vaccine. And out of that, 1% of patients admitted in hospital or with or died from cardiac arrhythmia, and there are 7,750 deaths of cardiac arrhythmia recorded. And they showed that there is an increased risk of cardiac arrhythmia following second dose of Moderna vaccine. My patient was giving the first 2 doses AstraZeneca, the third dose was Moderna, and in the other cases, AstraZeneca and Pfizer vaccine has reduced risk of arrhythmia. So that might be a case of vaccine-induced arrhythmia. The study results showed that the arrhythmia was atrial fibrillation, AV block, ventricular tachycardia, ventricular fibrillation, and SVT. My second case, when a bradyarrhythmia is a nightmare. Here, the tachyarrhythmia was my nightmare. A 45 years old male, non-diabetic, smoker, severe chest pain for 2 hours, developed cardiac arrest within 5 minutes of CCU admission, reverted to DC cardioversion, monitor showed VT, and this is the emergency admission ECG. And when he entered the CCU, he developed cardiac arrest. Emergency resuscitation done, tenecteplase was given, the patient was hemodynamically stable, occasional chest pain, there is regional wall motion abnormality, and this is after the tenecteplase. There is not evidence of successful thrombolysis is not. After 6 hours and pharmacoinvasive strategy, we check the angiogram. There is a dilatation of the right coronary artery, ectatic dilatation, and the proximal LAD has 70-80% stenosis. We straightforward stented the patient. If we carefully look the septal branches, because that will factor in later on, there is a septal branches, a small septal branches is occluded 99% in the angiogram. So we stented the patient straightforward, and this is the post-PCI ECG. On the next morning, the patient's ECG started to change. The right bundle branch block developed, and there is on the next day, the monitor showed that the complete heart block. We retrieved this ECG from the monitor, and the patient has no chest pain, but there is a slight reduction of blood pressure, 90/60. And we are in puzzle what to do. And this is after atropine. And we started iptifibatide, and after 4 hours of the iptifibatide, the ECG normalizes. So my mysterious explanation is that the occlusion of septal branch of LED may, by thrombus that may produce that may resolve by integralin, and we know that the septal branch supply the His bundle. My third case is a migration. This is not bird migration. This is migration of a stent. 45 years old male, hypertension, diabetic, non-STEMI 2 weeks back, CAG done in other city, and this is the lesion, straightforward lesion, PCI done with all precaution, 3.5 millimeter stent, 28 millimeter was given, and post-dilatation. After 2 months, the presented with severe chest pain, ECG non-specific changes, troponin was marginally raised, check CAG done. This is the ECG on second admission. Look at that. If the view is not so good, the stent is outside the flow of the RCA, and the distal vessel is almost totally occluded. So for clear view, the red mark is the stent's site. So how it can be occurred? That there is a new path of blood, and there is the distal flow is. So there are many questions, and so aggressive disease progression within 2 months. Can it be a hypersensitivity reaction to the stents? My mysterious explanation was an aneurysmal formation at the site of the stent, implantation followed by stent thrombosis. The remaining flow is outside the stent through the aneurysm. The cause might be hypersensitivity, most likely, and mycotic aneurysm may be another, but it is less likely that the patient has no fever after the procedure. And we have done the CT angiography. The stent is well visualized, and this is the CT angiography. The stent is outside the aneurysm, and there is no flow across the stent, and so this is the stent migration. And my fourth case, anaconda in the coronaries. This is the case of 55 years old female, diabetic, shortness of breath, chest discomfort on minimal exertion for prolonged period of time. ECG, I will show that. Echocardiograph, there is the anterior wall hypokinesia, and ejection fraction is 40%. So there is the old antiseptal MI, incomplete LVBB, LVH with strain, all thing here. So this is the coronary angiography. We can only cannulate the LCX. We cannot cannulate the LED. LCX is aneurysmal, and there is a flow, retrograde flow to another chamber, like dilatation. There is a, we first thought that is the coronary cameral fistula, but this is the LCX, another view, and the larger channels is there. And from LCX, the catheter dislodged to the RCA, and the RCA is anaconda. So this anaconda is filling the distal part of the LED, probably. The distal part, the view was not so, because we are using the 5 French catheter for transradial approach. So the visualization is not so good, but there is some visualization of LED. So is LED totally occluded? We first thought that. So my mysterious explanation is extremely aneurysmal dilatation of RCA and LCX. LED may be totally occluded, retrograde filling of part of the LED, and seems to be a coronary cameral fistula. But we have done the CT coronary angiogram. Look at that, the RCA and LCX arising from the LED, and RCA and LCX arising from the aorta, but LED arising from the pulmonary artery. This is the pulmonary artery origin, the front one. This is the LED origin, and the behind the LCX and RCA origin. This is LED from pulmonary artery, and this is the LED origin from pulmonary artery. This is the RCA origin from aorta. So this is an adult Al Kappa. Is it very, very rare case? Very, very rare. This is the origin of LED from pulmonary artery. We retrograde checked the echocardiography. We found then flow acceleration in the pulmonary artery. This is the flow acceleration. So there is a coronary steal syndrome. When there is the pressure in the pulmonary artery is low, blood still from the heart to the pulmonary artery. So for that reason, there is the pulmonary artery flow acceleration. And we can also recognize that hugely dilated right coronary artery orifice from the aorta. So there is no left coronary artery orifice from the aorta. So this is my first case, and my mentor, Professor Mir Jamal, was present, was there. He never seen in his life of intervention of long life. So L-kappa in adult is extremely rare. True incidence in adult is not known. It is estimated that 1 in 300 live births. Most of the patient died within first year of life. Symptoms usually arise within 2 to 3 months. Survival into adult life without surgery is possible, and there are few case reports in the literature. Thank you. Thank you for your patience hearing. This is my cath lab team.
Thank you. Thank you, Abdul Rahman. I think extraordinary presentation and also excellent to your archive also regarding these previous Dr. Abdul Momen cases. I think is the most interesting cases.
Thank you very much. In fact, all cases were very interesting, and we know that complications are common in all cath labs. If any cardiologist say that I did not have complication, it means that he has not done enough cases. The important point is that we should have patience when we should try our best. As Professor Gambhir rightly said, that there is always light at the end of the tunnel. Thank you.
We are moving forward. The next case, Dr. Kundu Gasuduzzaman. Dr. Kundu Gasuduzzaman, facts and fates of a planned to an unplanned game. Well, I think is the last case today's session.
Honorable Chairperson, respected panel of expert, moderator, teachers and colleagues. Assalamu alaikum and very good afternoon. Today my topic is fates and facts of a planned to an unplanned game. Let us see the brief history of my patient. A 53 years old gentleman. Risk factors were diabetes, hypertension, CKD, and family history of coronary artery disease. ECG was normal and echo was normal. Ejection fraction was very good. Cardiac troponin, 2 samples, consecutive samples were normal. A patient had thrombocytopenia and his diagnosed case of hepatitis B positive. An initial diagnosis was unstable angina, and I planned for coronary angiogram after hydration with normal saline. Let us see the angiographic view of my patient. Here you can see here, there is a lesion involving the proximal to the mid LED as well as the diagonal 1 and 2, but there is severe critical bifurcated lesions involving the diagonal one. It was Medina, class 111. And on the other side, you can see here, there is also significant lesion involving the OM, and it's a good sized vessel. If you look the right side, you can see here, there's no significant lesion in the right coronary system. So actually, this is not a critical case. I think my fellow colleagues or my colleagues who are sitting in front of me, everyone can do this procedure in a very simple way. But why I intended to present this case in this August gathering? Actually, I feel trouble in every step, starting from the wiring of the side branch up to the delivery of stent to the side branch. So, just I want to share my pain with my colleagues. Let us see what should be the next. Evaluation and management of thrombocytopenia. For this reason, I talked to my two consultants, hepatologist as well as the hematologist. They thoroughly investigate the patients and conclude that the patients had hepatitis B induced immune-mediated thrombocytopenia, and he had early stage of cirrhosis of liver, and FibroScan revealed that report was 14.7. And next, I talked to the cardiac surgeon as well as the patient and party, but the patient decline cabbage. And then we decided for upfront two-stent strategy, decay crash for the LED diagonal, and then stage PCI to LCX to AM. Wiring of the main vessels and wiring was trying to cross the side branch. Multiple attempts to negotiate the side branch, but failed to cross the lesion. And lastly, low pressure balloon dilatations of the main vessel, and it was thought that it might be change the carina of the bifurcational angle as well as the lumen of the main vessel. As because I tried all the maneuvers, whatever written in the textbooks, but I failed to cross the lesion to the side branch. And later, side branch occlusion occluded totally just after low pressure balloon inflations of the main branch, and patient developed symptoms, but finally, successfully wiring of the side branch after modification of the main branch lesion as well as the carina. Then I go for sequential predilatations of the side branch with 1.5 and 2 balloon at different atmospheric pressure. And then main branch predilated with 3 into 12 balloon, 1:1 predilatations with 10 ATM, but patients suddenly developed severe symptoms and ST went up, and due to acute main vessel closure. You can see here on the left and the right side. So, what should I do now? Should I proceed to the planned decay crash? Or should I proceed provisional single stent strategy plus minus kissing balloon dilatation, or unplanned bailout tap stenting technique? Let us see the procedure. A 3 into 38 millimeter DSC was placed in the main vessel and deployed at 12 ATM, which secured the main vessel patency and to alleviate the life-threatening ischemic symptoms as well as complications. Flow was established at main vessels, but D1 severely pinched as before. Main vessel stent was optimized with sequential post-dilatations with 3.512 NC balloon at different pressure. And then port was done with very high pressure, 20 to 22 ATM, and keeping the jail wire in the side branch. And remove the jail wire, and balloon supported wire across the main vessel stand start. And then sequential dilatations of the stand starts with 1.5 and 2 balloon with 12 to 14 ATM. And then kissing balloon dilatations with 2.515 and 312 NC balloons. But there was significant residual restenosis with ostial dissections of the side branch. Unfortunately, we decided to secure the side branch with a stent by tap technique. A 2.5 into 15 DSC was tried repeatedly to deliver the side branch, but failed. Then I took a body wire at the side branch and redo port with high pressure with 3.5 into 12 NC balloon. And body wire and port helped me to deliver the stand to the side branch. And then I advanced the uninflated balloon to the main branch and proper positioning of the stand. This could be done by subtraction stand boost may guide for precise positioning of the stand, as because precise positioning of the stand is the tricky step of T-stenting. And angiography after side branch stent deployment. And deployment stent was seen by stent boost. You can see here the proximal part of the ostium side branch is totally covered by the stent, and the distal part of the ostium, there is a slight protrusion of the side branch stent. Pull back side branch stent balloon slightly back into the main branch. And finally, simultaneous kissing balloon inflation after sequential dilatations of the side branch and main branch, and angiography after the final kissing balloon inflation. An angiographic result after the final pot. So my take-home message, TAF is a modified T-stenting and is an easier bailout provisional stenting strategy. IVAS OCT is an essential imaging tools for stent optimization, but subtraction stent boost may be a good alternative. Predilatations of main vessel at bifurcation may facilitate widening of the side branch in a selective cases by modification of the main branch lumen as well as shifting of carina. Port is mandatory, and body wire may help to deliver the stent into the side branch. Planned to unplanned technique may be a game changer to win the battle. Thank you, everyone. Thank you for patient sharing.
Thank you, Khaduk Asad. It's a nice demonstration of the provisional stenting. I think it is a good cases discussion. For any comments from Professor Rais Mondal, Rajshahi Medical College, Department of Medical.
Thank you, Dr. Asad. Thank you to Profs. Solve the problems in cath labs, and all the speakers are speaks different subsets in good way. So thanks everybody. Thank you very much.
Now, Dr. Samir Kundu, please, any comments regarding this complication session?
Thank you. My heartfelt thanks to all the speakers for their brilliant presentation regarding management of cath lab problems. Thank you very much.
Now I am requesting Professor Sufia Rahman, please closing the session. Professor Sufia Rahman, please close this session.
We had a quite interesting session, started with Professor Mir Jamaluddin, then Dr. Kalral, and then Ashok Datto, Gambhir, and Vijay Datto, Anisul Awal, and Abdul Momen, and now lately Khondokar Asaduzzaman. Actually, everybody has presented so very nicely, and we have already discussed after the presentation each time to the points we have highlighted again and again. So I think, because of the time, and I think it was a very good interactive session. And this type of session is more needed because it not only shows the complication or the problem they have faced, how to bail out. This is good for our juniors as well as seniors. They didn't have the experience. So thank you for all your attention, and thank you for having me here in this session. Thank you.